So once I had sort of learned more about this clinically, I decided to become a researcher, and the first thing I decided to do was look at the population level and see if there was really any phenomena here that was worth going forward with, that I could ever get NIH to pay me to study this. So I took the state of Michigan's Medicaid database, so these are the women you know, and I just asked, is having a PTSD diagnosis associated with having more pregnancy complications? And what we found is that yes, it was. Now this was 1994 to 1997 data. So DSM-4 came out in 1994. So PTSD being diagnosed in women was still pretty rare. It was very underdiagnosed. But nevertheless, in the state of Michigan, there were 455 pregnant women who actually had been diagnosed and used services for PTSD. So even then, nearly 20 years ago, it was not a small phenomena. And this type of data, it's claims data, it's just ICD-9 diagnostic codes. It's not optimal, but one of the things we found was that they did have more of the hyperemesis gravidarum, and that's one of the things I'm studying still today in relation to oxytocin. It's very interesting work. So once we knew sort of from the satellite view of the state that there was a problem, then my next question as a midwife and a feminist is, well, what would women want us to do about this? Because treating PTSD might be optimal, but do they want treatment for PTSD in pregnancy? And from this action research, we did ask women what they wanted. And we also learned from the stories that they told us. And this slide, even though it was research done with 15 women, I think is still some of the most useful research for clinicians, because it helps you take the people who come to you and sort of sort them into groups to know how best to frame your response. So the first group of women were far along in their recovery when they got pregnant. They were safe and well. They wanted the professionals they worked with to be collaborative allies, and their goal was to avoid being triggered and to stop the cycle of violence and be protective mothers. But then there was a group of women who were not safe. So they were still addicted, or they were being re-victimized in their adult relationships, and they had usually left family of origin. So they had very low social support. They were quite isolated. They wanted compassionate authority figures, so they wanted help to get out of the domestic violence or help with the drug use that they were doing. But they wanted professionals to understand that this wasn't just bad behavior. This was an adaptation from trauma. They wanted access to safety and treatments, and to have their needs for support met. The last group was a group that's a little bit hard to discern. It's more the bedside people who are going to notice this group. These are women who were not ready to know about their childhood maltreatment yet. What we found was usually they were young and they were not safe enough yet. Often they were still dependent on their family of origin. And so what they wanted the professional to do was to be a therapeutic mentor. So not to talk about the trauma overtly, not to refer them to therapy, but just to say, you seem really stressed, distressed. If you ever need anything, you can come to me. I can refer you. I can get you information. And they wanted us to lay groundwork for their maternal development. So focusing on being a safe and protective mother without really needing them to talk about what had happened to them. So I want to let you know that all of these studies that I'm talking about are published papers, and you can get almost all of them either by sending me an email, which I'll put my email up on the last slide, or you can go on to Google Scholar and put my name in, and they will pop up, and you can kind of shop through and usually download the PDFs. So there are ways that you can kind of read these at leisure. So the next thing we did when we knew what the women wanted from us was we did a pilot study. And the reason I show this slide, even though it's really old at this point, is because I think it's a really good graphic. The higher you are up on this axis, the more optimal your pregnancy and labor and birth was. The more out here you are, the worse your PTSD is. And what you can see is there's a linear relationship of suboptimal pregnancy process and outcomes, more interventions, as you get more affected by PTSD. So on the strength of that data, we were able to do a $2 million study that we finished in 2010, and we're still writing up the papers, that looks at the psychobiology of PTSD and adverse outcomes of childbearing. And the team for this was very interdisciplinary, midwives, psychiatrists, statisticians, and we had an army of perinatal nurses who helped recruit for this study, and also a number of RAs from many disciplines. And the research question was just, what are the effects of PTSD on childbearing outcomes? We did it at 3 hospitals to get a large enough sample. There were 1,600 women in the study, and also to get a sample that kind of resembled humanity. We had to mix Ann Arbor and Detroit and stir in order to get that to happen. But Henry Ford, Hutzel, or Detroit Medical Center, and UMHS were the hospitals. Just to give you an idea of the study, we collected all kinds of data. We surveyed the women with structured telephone interviews 3 times, early pregnancy, late pregnancy, and 6 weeks postpartum. We had permission to extract their medical records so we'd know the labor and delivery and nursery information. And we also got saliva for stress hormones, and later we got more money to go back and get saliva for DNA. And the biological work is what we're still analyzing. So the bottom line results are that the prevalence of PTSD in the lifetime of pregnant women is 20%. But the number who actually meet diagnostic criteria during the pregnancy is 8%. And that's a very stable number in the literature that's come out since and in our findings. But there was a social gradient. So in Ann Arbor, where 90% of the women are white and privately insured, the rate of PTSD in pregnancy is 3%. And in Detroit, where 90% of the women are African American and publicly insured, the rate of PTSD was 14%. So you can see that we really need to frame interventions for low resource settings. The biggest risk factors for being fully symptomatic in pregnancy were history of childhood maltreatment. That gave you a 12-fold risk of meeting diagnostic criteria. And also a history of reproductive trauma, which gave you an 8-fold risk. So these were all women who were expecting to give birth to their first child. So the reproductive trauma that they were talking about could have been from a previous miscarriage or loss prior to 20 weeks, or from an elective termination, or from in vitro fertilization or other procedures that they went through in relation to reproductive health. And we actually wrote an entire paper about that because we had wonderful data. Not all women consider these events to be traumatic. So we actually have really nice data that describes the different ways these things play out in women's lives.